Good evening, everyone, and welcome back, Dr. Tushar Bhai. And it's a great pleasure to be with you on this dais. And I love the topic for simple reason that this is a topic which affects one and all. And more so, I'm on both sides of the table when it comes to this topic of prescribing errors in the elderly because we fall now in the same category. And we know that in India, there are in 2019 survey, India has 13.9 crore people who are above the age of 60, and it's soon going to be double by next 40 years. So, as in one of the topics when I discussed the same, I said that India will need more geriatricians than pediatricians because we now know that pediatric diseases are really becoming less, and except vaccinations, they don't have to offer much. While geriatricians a huge scope, there are so many patients waiting for the right treatment because we know that old age something nobody wants it, but then with increasing age expectations, we have more and more people falling in that group. Elderly people are different than the younger counterparts in the sense that they have more uh, diseases, they have more pathies that they are taking advantage of, whether being allopathy, homeopathy, and so many others. Then they have many different physiological restrictions. The drugs effects are also different, and we cannot have a better person than Dr. Tushar Shah, who is a clinician par excellence, who is not only working in the multi-facility hospitals in Mumbai, but also a multifaceted person. As Dr. Nivita rightly said, he is a humorist, he is an author, he is a poet, and also he will talk of mainly the clinical aspects. I happen to have his earlier talk also about the uh, acute febrile illness, an absolute clinical topic. And we are eagerly awaiting, sir, for your discourse. And that is why probably he doesn't want the slides because he is the one who talks, keep on talking. And we'll be interrupting you, sir, for the sake of your rest and also the continuity. So over to you, sir.
Thank you, sir. Dr. Mahadev, I would in fact like you to interrupt whenever because you can not only uh, add to what I say but also rectify any errors that I might make. Today's topic, medication errors in the elderly, I would like to rephrase the topic as ways in which our treatment can kill or almost kill the elderly because we truly can be murderous when we treat elderly patients. It is said that in the US, about 100,000 patients die because of medication errors, and most of these are elderly patients. So we can save lives by just not killing patients. So that is what we should be doing. Okay, so how can we harm patients in such a way that we can almost kill them? Let me go one by one. If I tell you that we can cause heart attacks, you will be surprised, and therefore you may even not believe me that how can doctors' medications cause heart attacks. So it is known that 5 days, as little as 5 days of non-steroidal anti-inflammatory drugs given to susceptible individuals like elderly patients with atherosclerotic disease, as few as 5 days of NSAIDs can cause an acute myocardial infarction. Now we see prescriptions of NSAIDs being given fairly frequently for fairly long periods of time by everybody. I would like you as physicians to see these prescriptions and cut down the duration at least of the NSAIDs because often NSAIDs are given for weeks or months, especially for orthopedic problems. The NSAIDs that are most responsible for cardiovascular side effects are the COX-2 inhibitors. Etoricoxib, which is the one COX-2 inhibitor approved in India, etoricoxib is a drug that should be relegated to the dustbin. Please do not use etoricoxib ever in your life. Etoricoxib is a favorite amongst orthopedic surgeons. It is a hugely marketed drug with a lot of brands and a lot of companies pushing the drug. Please do not use etoricoxib at all. If you want to use a cardiac safe, there is nothing like a cardiac safe NSAID, but relatively cardiac safe NSAID, please use naproxen, ibuprofen, but do not use COX-2 inhibitors. So that is one. If you eliminate etorecoxib from your prescription, in your whole lifetime, you will have saved a few lives. You can cause congestive heart failure by NSAID therapy. You can cause myocardial infarction by NSAID therapy. Any patient who's on etorecoxib or any other NSAID given by somebody else or you, on every follow up, please check the blood pressure, please check for edema feeds, look for breathlessness, and rectify these problems by omitting the NSAID if you can. In the cardiovascular system, accelerated hypertension can be caused by many drugs. NSAIDs are one of them. You can cause a stroke by causing accelerated hypertension. But another group of drugs that can cause high blood pressure is decongestants. We all know that phenylpropylamine was banned because of accelerated hypertension. Similarly, phenylephrine is also a decongestant which has sympathomimetic activities, and the phenylephrine is a content of several decongestants combinations like Sinarest, Sinus 77, etc. Try to avoid phenylephrine in the elderly, and especially in the elderly who have heart disease or who have high blood pressure. Besides heart problems, you can cause, of course, multiple systemic problems. One important problem in the elderly caused by medication errors is altered sensorium or encephalopathy. If you give a patient anti-diabetic medication and if you overdose the patient, or if the patient's creatinine is high and therefore the clearance is not very good, you may cause hypoglycemia. So one simple suggestion here: start low and go slow in treating diabetes. You see a blood report of 250 fasting, 350 postprandial in an elderly patient. It is very tempting to start something like glimepiride, metformin, BD, or TDS. Please don't do that in the elderly. Start low, go slow is the dictum that you have to follow in the elderly. Hypoglycemia can, as you know, kill a patient, can cause strokes, can cause fractures by falls. So take care of hypoglycemia. Another CNS encephalopathy problem, the commonest drug group that causes hyponatremia, as you can imagine, is the diuretic group. One important thing to remember is that the thiazide group, that is hydrochlorothiazide, chlorthalidone, indapamide, cause more hyponatremia than the more potent furosemide drug, that is a loop diuretic. That is because the loop diuretics cause equal excretion of sodium and water, whereas hydrochlorothiazide, chlorthalidone cause more sodium loss, less water loss, and therefore hyponatremia is common. Just make sure that any patient who receives a thiazide diuretic is checked, if elderly, for hyponatremia on a periodic basis. Another rule that I follow and that I think we should all follow in the elderly: never exceed the dose of hydrochlorothiazide to more than 12.5 and chlorthalidone to more than 6.25. As you know, there are many combinations. For example, telmisartan with chlorthalidone. Many of these combinations contain 12.5 milligrams of chlorthalidone. Remember, 12.5 milligrams of chlorthalidone is equal to 25 milligrams of hydrochlorothiazide. You must not give 12.5 at all of chlorthalidone in the elderly. Limit yourself to 6.25 of chlorthalidone whenever you do give. Another group of drugs that cause hyponatremia are the carbamazepine, oxcarbazepine, are drugs used in neuralgias like trigeminal neuralgia and as antipsychotic drugs in the case of oxcarbazepine. Especially oxcarbazepine causes hyponatremia. Any patient on oxetol or any such similar drug, oxcarbazepine, you must check for hyponatremia. In fact, if you see an elderly patient with altered sensorium, the two most common causes of altered sensorium without any injury or fall are hypoglycemia and hyponatremia. First things to consider would be those two, and most of the causes of hypoglycemia and hyponatremia are drug related causes. So also remember that SSRIs, SNRIs, antipsychotics all can cause hyponatremia. So if your patient is on fluoxetine or paroxetine or mirtazapine, if the patient has hyponatremia, the drugs, psychiatric drugs, may be responsible for the same. So again, for that reason, psychiatric drug doses should also be kept low and increased regularly monitoring for hyponatremia. The another area of side effects that you can cause and cause actually deaths or near deaths is drugs that cause falls. Falling, a patient can fall, get a subdural hematoma, get a fractured neck femur, and significant morbidity. And what will cause falls caused by you? The, the commonest drugs that will cause falls are the drugs that cause postural hypotension. If you start an elderly patient on a prostate medicine like tamsulosin, remember tamsulosin is an alpha blocker, causes postural hypotension. If you cause postural hypotension and the patient wakes up in the night to go to the washroom, suddenly the BP drops and the patient falls. How do you prevent that? You must start low. So when you use combinations of say finasteride with tamsulosin, they are fixed dose combinations. You will always have zero point 0.4 milligrams of tamsulosin in those combinations. Don't start at zero point 0.4. Start at zero point 0.2 milligrams of tamsulosin and go up. That reduces the chance of first dose hypotension, which is a common phenomenon with alpha blockers. All antihypertensive drugs can cause postural drop. What do you do about that? Any patient who comes to your clinic, if elderly, if on antihypertensives, never let the patient leave your clinic without checking the standing blood pressure. You will be surprised so many times that the supine reading is 160 by 80 and the standing reading is 110 by 70. The drops can be very huge, and you must remember that you can afford a systolic blood pressure of 170, but you cannot afford a postural drop of 50 points. So you will have to judge your doses to prevent falls. That is very important. Okay, uh, let's keep on the musculoskeletal system and how you can damage the patient's musculoskeletal system by prescriptions. Statins. Statins are very commonly used drugs, and statins, of course, are given to all patients who have demonstrable or clinical atherosclerotic cardiovascular disease. The problem with statins is that they can cause significant muscle aches, and more important than muscle aches, they can cause muscle weakness, and that itself can cause falls. So make sure on every follow up of a statin taking patient, ask them about muscle weakness, gait problems, and muscle pains, and adjust the dose of statins. Test for CPK if necessary. You must also remember that the utility of statins reduces after the age of 80. Very elderly patients try not to initiate statins or even lower or withdraw the statins because statins improve long term morbidity and mortality. They're not for immediate benefit like aspirin can be for immediate benefit. So if the patient's 10 years survival is not significant, you need not give statins to such patients, or you can withdraw statins. Statins, of course, we know can also cause diabetes. So every 200 to 50 patients you give statins to, you can cause one new onset diabetes. So statins should not be given easily without exactly determining the criteria for giving statins. And there are very rigid criteria for. If you see a patient with LDL cholesterol of 160 or even 170, a patient is 70-year-old, first time LDL, no atherosclerotic disease, no diabetes. Don't worry about the LDL cholesterol of 170. Often the patient will not need calculate the 10-year mortality by the risk calculator, cardiac risk calculator, give statins only if the criteria for giving statins, which are very rigid, are satisfied. We tend to prescribe more than we should. We have OCD. OCD is obsessive compulsive drugging. We do not need to have OCD. We must not treat every report. We must not treat every symptom. About that, whenever you have a patient who has a symptom, you must ask the patient, does this symptom require my help, the doctor's help? Does this symptom bother you enough to cause need for medication? For example, if a diabetic patient comes with junjunahat in the feet, paresthesia in the feet, our automatic prescription goes to gabapentin or pregabalin. Ask the patient few questions before you determine the need for therapy. If you ask the patient, how many times in a day are you bothered by this symptom? And they will often tell you a few minutes or a few hours a day. Is this symptom very bothersome, disturbs your lifestyle? No, it doesn't disturb me so much, but you asked me for symptoms, so I told you my symptoms. The very fact that patient is given you a symptom does not automatically mean that you have to treat that symptom. You must ask the patient, does this bother you? And then think of treating. Gabapentin and pregabalin are the most misused drugs in neurology. You have to stop, reduce, abandon their use when not indicated. That is very important. Pregabalin and gabapentin cause severe giddiness at the very first day of giving. You'll have so many patients who will tell you that I could not tolerate the drug, and you must, and they can cause falls. So you must be careful about giving those drugs. Another musculoskeletal problem is caused by PPIs, proton pump inhibitors. We are all very fond of giving elderly. Pantoprazole should not be given for more than 8 weeks at a time. Mandatory rule. Do not give pantoprazole. Ask them to take some antacid, like a liquid antacid, and on an SOS basis rather than pantoprazole on a regular basis. Only if the patient is on steroids for long term for any reason may you give pantoprazole for long term. Otherwise, please avoid giving, and giving pantoprazole with domperidone as a combination has really no logic for the long term. You cannot give this combination for long term. So avoid that, because once you cause achlorhydria, there is nothing to reflux, and domperidone does nothing in that situation. Avoid such combinations which are illogical. Okay,
Just to add, sir, can I add one more thing? Yeah.
please.
Look, Tushar, bhai, yesterday only we discussed in our cutting edge show about the recent release of ECG, American College of Gastroenterology's GERD guidelines. And they
Okay.
exactly said what you said, that please don't use PPI more than 8 weeks. And if they don't respond, it's better to go for endoscopy. And PPI has many problems, like as you rightly said, the vitamin B12, magnesium deficiency, osteoporosis, and is also known to cause acute interstitial nephritis and later on many problems. So, and whenever we give, we should give it before meal, 30 to 60 minutes before meal, other than giving after meals or at bedtime. And as you rightly said, don't combine with domperidone, especially in elderly people, and there can be extrapyramidal side effects along with that. So,
Sure, true.
very well said about PPI. Go ahead, sir.
I think one general rule that we should all follow is we should become under prescribers rather than over prescribers, as a general rule, especially for the elderly. The definition of polypharmacy is five or more drugs given to an elderly person or any person. These five drugs do not include vitamin supplements or calcium. Five or more drugs. One important thing to remember is, for every one drug you add to the elderly patient, one side effect will occur. Every drug you add, one side effect is mandatorily happening. So you must take care of those side effects. Another side effect that the patient gets is related to the bladder and then the bowel. Let me discuss the bladder first. Uh, Acute urinary retention can occur with any anticholinergic drug. You can give something as simple as Buscopan, that is dicyclomine, and you can get acute urinary retention. You can give amitriptyline, which has anticholinergic side effects, and it will cause acute urinary retention. So take care of that whenever you prescribe a drug. Most neurological drugs, many psychiatric drugs, many GI drugs have anticholinergic side effects, and you must avoid that. Actually, there is a list called the Beers list, BEERS, Beers list in geriatric pharmacology. You Google beers for geriatrics and you will get the list. The beers list basically is a compilation of drugs that harm the elderly, the senior citizen. And it's a useful list to go through so that you know what drugs have to be given carefully, if at all.
Yeah, so one of the
Another
drugs,
area is
antihistaminics are also causing lots of anticholinergic side effects. So, and common
absolutely,
prescription,
especially the first generation
first generation.
antihistaminics, especially cause a lot of side effects. So, yeah. Another area is causing constipation. The elderly are bothered about two things in life generally: sleep and bowel movement. If their sleep is good and their bowel movement is good, the elderly considers himself or herself happy. The relationship with their son or daughter in law or wife does not matter as much as the relationship of the bowel and the bladder and the sleep. So you must keep the bowels open, at least by not using drugs that cause problem. The commonest drug that causes constipation in the elderly is calcium. Oral calcium supplements. Any patient who is on calcium, elderly need calcium. You cannot avoid giving calcium. But any elderly patient who who comes to you on follow-up, who is taking calcium, please ask the patient, do you have constipation? If they tell you that I have so much constipation that I have to do finger evacuation, then please remove the calcium and just increase dietary calcium. You can't make the elderly person live with everyday severe constipation. So calcium is one drug that causes, and there are in antihypertensive, remember, calcium channel blockers cause a lot of constipation. So any patient who comes, who's on diltiazem especially, but even amlodipine, if they have constipation, you may have to consider switching the antihypertensive drug. Uh, so, multiple anticholinergic drugs, like anticholinergic drugs, cause urinary retention. They cause dryness of mouth. They cause constipation. All are very bothersome side effects for the elderly. So, any drug that has anticholinergic effect has to be given with great thought and in a small dose. Another thing that we see in the elderly is something called a prescription cascade. What is a prescription cascade? Prescription cascade is when you give one drug which causes a side effect, you give a drug to treat that side effect, that drug causes a side effect, etc. I'll give you an example. You put the patient on amlodipine. The patient comes to you after 1 month with edema feet. You do not remove amlodipine because you do not think that amlodipine is the cause of edema feet, which it is. Now you give a diuretic to that patient who has come to you with amlodipine. The diuretic causes hyponatremia. You increase the salt intake, you give something like fludrocortisone uh, for the hyponatremia. And then that salt intake causes increased blood pressure. And then you think, okay, I should increase the amlodipine to tackle the high blood pressure. And that continues. That is a vicious cycle that you have created by treating a side effect with another drug. Never treat a side effect with another drug. Just remove the drug that is causing the side effect. That should be done. Uh, so that is about.
Can I interrupt, sir, for a minute about the
Yes, sir, please,
prescribing
please,
cascade?
please.
You said rightly that many times we overlook the side effect of a drug that we had prescribed. So, as a rule of thumb, we should first think of the drug if there is a new symptom after prescribing a new drug. And one of the example you said is another is ramipril. If you give any of the ACE inhibitors, patient gets cough, and we prescribe codeine, he gets constipation. We prescribe laxative. So, this is the prescribing cascade when for a simple omission of a drug would have solved the problem. And
Solve the problem.
yes,
Absolutely true. Absolutely true. Um, Another area that I would like to discuss is about diabetes medications. A new group of diabetic drugs, that is SGLT2 inhibitor, not new but relatively new drug group, has become very popular. SGLT2 inhibitors, as you know, dapagliflozin, empagliflozin, canagliflozin, and more are in the pipeline. These new, not new, but these SGLT2 inhibitors have become very popular because they have cardiac protection and renal protection. Both these groups of drugs, this group of drugs have both protections. And more elderly patients are being given SGLT2 inhibitors. I have no argument against giving SGLT2. They are good drugs. They control diabetes. They cause weight loss in the overweight patient, and they protect the kidney and the heart. Good drugs, but drugs with side effects. And since they are relatively new, for us to know the side effect has become even more important. SGLT2 inhibitors cause glucosuria. They remove the glucose from the bloodstream into the urine, and by causing glucosuria, they cause dehydration because water goes with the glucosuria. Any patient on SGLT2, you must check for dehydration, postural hypotension, and make sure that a patient on SGLT2 ideally is not getting a diuretic. Ideally, should not be getting both a diuretic and SGLT2 because you will cause dehydration in that patient. Also, SGLT2 inhibitors are very commonly causing penile or vaginal fungal infections. Infections at the introitus in the female and at the penis in the male. Extremely common, and often the patient will not disclose this to you on the follow. Every patient who has SGLT2, please ask for a rash or itching at the introitus or penis, and you'll be surprised that nearly 50% of patients on SGLT2 will come up with fungal infection at that site. Another group of drugs that is very important in the elderly is the opioids. The opioids that we use in India are codeine, tramadol, and tapentadol, besides morphine and fentanyl, of course. Morphine and fentanyl are not so much in the domain of the family physician or general practitioner. More so are tramadol and tapentadol. Please remember that they have to be used with extreme care. The commonest indication of using tramadol tapentadol is osteoarthritis, where you give paracetamol, patient does not get better. You can't give NSAIDs because the elderly patient has heart disease or kidney problems, and therefore you give tramadol or tapentadol. Be careful with the dosing. Be careful with even prescribing the drug. If you are prescribing an opioid, between tramadol and tapentadol, and this is not a very well known fact, between tramadol and tapentadol, choose tapentadol always. Tramadol is a pro-drug metabolized by the cytochrome P450 coenzyme and converted to an active form. There is such a large degree of genetic heterogeneity that some patients will metabolize it much faster than some other patients. So in some patients, tramadol will have no effect at all because the conversion from prodrug to active drug does not occur by the cytochrome P450, and some patients will convert it so fast that tramadol will cause drowsiness, falls. So tapentadol does not get metabolized by the cytochrome P450. Hence, if you do use an opioid, use tapentadol and not tramadol. The dose is the same, 50 milligram tablets, etc. But we do know that mortality increases with opioid drugs. So you have to use them very carefully. Similarly, we have codeine, but again, codeine luckily is not available freely. We have syrups which contain codeine, and we have a codeine paracetamol combination available. But chiefly, we do use codeine only in patients who are terminally ill, very severe pain. Unfortunately, codeine, all these opioids cause severe constipation, and hence our use should be limited. Uh,
Sir, if I can add about the tramadol,
Please.
Tramadol, as you rightly said, is probably more prescribed than what it should be because it's also metabolized, means one of the metabolism MAO inhibitions and many side effects. And whenever we have nausea with the, it's not easily tolerable drug. Whenever there is nausea, we tend to prescribe ondansetron. Ondansetron and tramadol is a very, very deadly combinations. And many drugs cause QT prolongations, and one of them is tramadol, ondansetron. And tramadol and linezolid again are another dangerous combinations, which we feel that both are very safe drugs. So tramadol has definitely more drug-drug interactions. So is with linezolid, and so now is ondansetron. So these are the drugs we think that they are safe, but they are not. So ondansetron is one more drug I think we should be more concentrating while prescribing.
Correct. Since you mentioned linezolid, let me talk a little bit about antibiotic therapy in the elderly. One group of antibiotics that you should not give as first choice antibiotic is quinolones. In the elderly, avoid quinolones as far as possible. Quinolones cause musculoskeletal problems. You all know about tendinopathy due to quinolones, but quinolones can also cause severe dysglycemia, hypoglycemia, sometimes hyperglycemia can occur due to quinolones in diabetics, especially. Quinolones are notorious for causing delirium or encephalopathy, and again a problem. There is a black box warning related to quinolones for aortic aneurysm rupture or dissection. And so quinolones have significant side effects. And we use ornidazole or fluoxetine combination in any patient who comes with diarrhea very commonly. Such an illogical, nonsensical combination to use. Do not use antibiotic with ornidazole or imidazole combination ever. Be sure of what the clinical diagnosis is and use one or the other. So, as a first choice antibiotic, quinolones are rarely necessary, and you should try to avoid quinolones as far as possible. Use penicillins, use macrolides if necessary. The second group that I want to talk about is macrolides. Within macrolides, you know macrolides, azithromycin, clarithromycin, the very useless roxithromycin, the
Mhm.
outdated erythromycin. So we, amongst the macrolides, in the elderly, avoid clarithromycin as far as possible. Clarithromycin is a favorite amongst pulmonologists because they use it in atypical pneumonias. Use azithromycin whenever you have to use something for atypical pneumonia. Clarithromycin causes significant QT prolongation. Clarithromycin also causes significant drug interactions with many drugs through the cytochrome P450 enzyme system. For example, if the patient is on atorvastatin and you give clarithromycin, the levels of atorvastatin can rise significantly, causing myopathy. So the number of drug interactions are so many with clarithromycin that you will never know what hit the patient. So don't use clarithromycin in the elderly as far as possible. Sir said about linezolid, Dr. Desai said about linezolid. Linezolid is a drug, whenever you give linezolid, linezolid, as you know, is a drug given for gram-positive infections, typically given for MRSA. And linezolid has drug interaction, as he said, with SSRIs and tramadol both. Linezolid causes serotonin
No.
syndrome if given with SSRIs or with tramadol. So if a patient, for example, is on an SSRI, as you know, sertraline, fluoxetine, paroxetine are SSRIs. If the patient is on an SSRI and you have to give linezolid, you must omit the SSRI before you give linezolid. Similarly, linezolid should not be given with alcohol, with some cheese. So be careful about linezolid in the elderly who is receiving other drugs. Uh, Amongst antibiotic groups, as you know, uh, penicillins, extended spectrum penicillins, ampicillin, augmentin, like drugs are relatively safer in the elderly than the other drugs. So be careful about another drug that is very important and very commonly given in the elderly antibiotic is nitrofurantoin. Nitrofurantoin is a urinary antiseptic or antibiotic, if you may. This is very commonly given for prolonged periods in the elderly who get recurrent UTI. Nitrofurantoin now is recommended against in people above the age of 65 for long term because it causes lung fibrosis, chronic liver disease, peripheral neuropathy. Nitrofurantoin causes all these three, and in the elderly, you should avoid nitrofurantoin except for short courses. Yeah, so there are many things in geriatrics which are a little dangerous to the patient, and we have to up to date ourselves for this. I think I have covered some things that I wanted to cover. I don't mind opening up the chat, or Dr. Madhav, if you have any comments.
One more thing is about the use of eGFR, because that is what really you would like to stress about every patient rather than going for only serum creatinine. A patient at the age of 70 with a serum creatinine of 1.2 and patient of 32 years with a serum creatinine of 1.2 have mass difference, almost half eGFR if you calculate by the, and it's easily available now, it's on our hand that we can do. So what about your opinion about eGFR?
Yes, this is an important area which I skipped. But eGFR must be calculated in elderly patients when you are thinking of giving some drugs. For example, simple metformin, simple example. Metformin should not be given if the GFR is less than 30. Similarly, SGLT2 inhibitors should not be given if the GFR is less than 30. So if you have calculated the eGFR, you may avoid certain drugs which are going to cause a toxicity to the patient. And as Dr. Desai said, eGFR calculators are easily available. One suggestion is don't use the Cockcroft-Gault formula, which now seems to be outdated. Use the MDRD formula if you like, which is, and there are other formulae, but I use the MDRD formula. You can easily Google search for MDRD eGFR formula and calculate the eGFR of the patient based on the patient's age, weight, etc. And yeah, so very important to calculate every time you check. There are some antibiotics which cannot be given if eGFR is low. The safe antibiotics in patients who have a low eGFR are the penicillins and the cephalosporins and the macrolides like azithromycin. Doxycycline is safe in patients with low eGFR. Clindamycin is safe. Linezolid is safe. So there are some safe antibiotics that you can use if the GFR is low. Yes, sir.
Yeah, yeah. When you are talking about the phenylephrine, I just wanted to add, but missed it, that even nasal drops like Otrivin, which now we see in the print media and in the electronic media as an advertisement, it also suits up the blood pressure after initial drying effect. So should we not be?
Yeah, we should. So the thumb rule in oxymetazoline and xylometazoline, which are the nasal decongestants, like Otrivin is a brand name. The thumb
Yeah,
rule is never used for more than 3 days if you do use in the patient. Another side effect is that they cause what is known as rhinitis medicamentosa, meaning they actually cause rebound congestion of the nasal mucosa when they are stopped, and that causes chronic rhinitis in many patients. So yes, they are drugs which should be used for very short duration.
another drug most commonly overused or abused is the febuxostat for a little rise in the uric acid. So your take about the febuxostat prescriptions?
So one thing that I teach students very commonly is treat the patient, not the report. One very important thing to tell everybody is people will see a uric acid of 7.5 and they will start either xyloric, that is allopurinol, or febuxostat.
Yeah.
Don't do that. If the patient is asymptomatic, if the patient is not CKD, not a chronic renal failure patient, if the patient does not have any history of kidney stones, do not use these drugs. They are not to be used lightly. So the absolute value of uric acid should be 9 or more to start these drugs in a patient who doesn't have history of gout or stones. So 7.5, 8.5 are not reasons to start. And one must remember this: febuxostat now in the US comes with a black box warning. Black box warnings are warnings given which for things that can cause death, for things that can cause severe morbidity. The black box warning for febuxostat is increased cardiac mortality due to febuxostat. So you must not use febuxostat lightly at all. Thank you, sir, for reminding.
And another thing is that we often overlook is that the patient receiving the non-allopathic drugs, herbal medicines or supplements, and drugs prescribed by other consultants. If I am looking after the patient, probably somebody else is also looking after the patients. And I am prescribing one analgesics or anti-inflammatory, the another is received by another. And so about the calcium and vitamin D supplements. Too many,
Yeah,
too many.
let us
So
yeah let us talk about the supplements first. Uh, so polypharmacy is a problem, right? It is said that any patient who is receiving 10 drugs, which includes the vitamins and supplements, 80% of patients make mistakes on a daily basis. That is the statistic. 80% of elderly patients who receive 10 or more drugs make mistakes in taking the drug on a daily basis. Our job as family physicians is to remove unimportant drugs, coenzyme Q10, Nephro-Save, Cardiovit, all these drugs which have, one thing I always teach my students is, if there is any brand which has the name of an organ system in the brand, that is usually a placebo. For example, Nephro-Save is a placebo. Neurokind is a placebo. Cardiovit is a placebo. Hepato something is a placebo. So try to remove the placebos. Patient doesn't need such a degree of polypharmacy. And yeah, as you said, rightly, sometimes two doctors are treating the patient. There is an overlap of prescription. Most people don't know what is happening through the other consultant. Most people don't know what drugs have been started. So you will often, I have seen patients getting three antiplatelets. They get a clopidogrel aspirin combination also, and then they get a separate ecospirin also. So many things happen which are due to not just polypharmacy, but polydoctory, multiple doctors seeing the patient. So I think that has to be taken care of by the central family physician, who's currently the most important person for the geriatric patient.
one of the participants of this today's symposia is also asking about how much ethanol can be permitted in an elderly.
So initially, sometime back, we used to say that six large drinks, 60 ml of spirits per week would be okay. Now we know that not a single drink per week is okay for anybody. What happens is, our main concentration was on the liver when we spoke about alcohol. The liver problem is dose dependent. The liver problem is dependent on how many drinks per week for how many years. Now we know that the cardiac and the neurological problems related to alcohol can occur with small doses of alcohol. So, current recommendation, not a single drink is safe. Now you will obviously individualize this. The patient will want to take alcohol. If they want to take alcohol, you will have to individualize this. If the patient has an ejection fraction of 35%, you will not permit drinks. If the patient is starting to get memory problems, cognitive disturbance, you will not permit drinks at all. So you will have to take a call on an individual basis.
Uh, Another questions from the audience is about the antifungal drugs, itraconazole and fluconazole, all that we prescribe probably more often than we should be. So your take on that.
So, one thing that we must remember is that fluconazole is a drug for candidiasis. Itraconazole is a drug for tinea. These are the two commonest fungal infections we see in our practice. So, for example, if an SGLT2 inhibitor causes fungal infection at the penis, candidiasis, and fluconazole is good for that. If a patient has diabetes uncontrolled and has groin or axillary tinea, that does not respond to fluconazole, that responds to itraconazole. So, one thing about itraconazole has, like clarithromycin, multiple drug interactions. And itraconazole, when you give, please see the other drugs that you are giving. For example, itraconazole warfarin causes trouble. Itraconazole with some beta blockers causes trouble. Itraconazole with atorvastatin causes trouble. Itraconazole with alfuzosin causes trouble. So you must remember which drug interactions occur. Since we are on that, I'll just tell you this. There are some drugs that we have to put in the dustbin forever, lifelong. For example, I told you about etoricoxib. We cannot use etoricoxib. Similarly, in statins, there are three statins which are more commonly used: Simva, Atorva, and Rozua. And of course, there is now pitavastatin, etc. But there is no reason to use atorvastatin and simvastatin now at all. Simvastatin and atorvastatin have significant drug interactions through cytochrome P450 enzyme system. Rosuvastatin does not have interactions through that system. Do not use, because the cost of rosuvastatin is not much more than the cost of atorvastatin. Stop using atorvastatin. Stop using etoricoxib amongst NSAIDs and amongst alpha blockers. You know that there are prostate related three alpha blockers: amsulosine, silodosin, alfuzosin. Stop alfuzosin completely. If a urologist prescribes alfuzosin, you change it to silodosin or tamsulosin, because alfuzosin has significant drug interactions. And in the elderly, you will never know who will prescribe. A dermatologist will prescribe itraconazole. The dermatologist does not know what is alfuzosin. They don't know the brand names of alfuzosin, and they will cause a drug interaction where alfuzosin will cause severe hypotension, and the patient will fall. How will the patient fall? The levels of alfuzosin go up when itraconazole is given, and the patient will fall. So and the dermatologist has no idea that this can happen. So you have to take care not to initiate drugs if there is a replacement available, which causes less drug interaction. Yeah, sorry.
Yeah, one of the viewer also want to know about, can adrenaline be given safely in a rural setup?
I suppose he's asking for adrenaline for asthma. I mean, adrenaline for anaphylactic shock, everybody gives.
Yeah,
But let me talk about both situations. Adrenaline for anaphylactic shock, one important thing to remember is has to be given intramuscular and not subcutaneous, not intravenous. Anaphylaxis, intramuscular adrenaline. About asthma adrenaline, I think the use of adrenaline asthma should be stopped. We have so many good alternatives, including nebulization, etc., that asthma should not be treated with adrenaline at all. Yes, sir.
yeah. Then most of the elderly people are receiving multiple cardiac drugs. One of them being the anticoagulant and antiplatelet drugs. So, with the availability of NOAC, new oral anticoagulant drugs, should we still be prescribing warfarin?
Okay, so let me tell you, talk about both antiplatelets and anticoagulants. First, I'll talk about antiplatelet. The commonest problem with antiplatelet therapy is that dual antiplatelet drugs are continued for very long term, too long
Correct.
term.
Yeah.
We all know that aspirin, clopidogrel are given after an angioplasty, for example. The current recommendation is 1 year is enough for giving dual antiplatelets after a stent placement. When the patient goes to cardiologist, the cardiologist does only CT all, meaning the patient continues to get dual antiplatelet therapy for 1 year, 2 years, 3 years. In a geriatric patient, you cannot afford dual antiplatelet for life, because the patient will fall, will get a hemorrhage, will get a spontaneous bleed from the bowel due to the dual antiplatelet drug. So always, if the patient on dual antiplatelet therapy and if 1 year has passed since the interventional event, then you please call up the cardiologist and say, what do you say to the cardiologist? There are two drugs going on. Can I stop one? What will the cardiologist say? No, you cannot. So what you have to say is, there are two drugs going on. The patient has some blood loss in the stool. Can I stop one drug? And the cardiologist will happily say yes. Sometimes we have to lie to get the cardiologist to do the right thing. Uh, about the anticoagulants, so as you said, the novel oral anticoagulants like apixaban, dabigatran are available, and warfarin is often used as the more common anticoagulant. Can we replace? We can replace. We should replace. There are a couple of things to know here. When we give newer or novel oral anticoagulant, we are giving for non-valvular atrial fibrillation. What are we giving it for? We are giving it for long term. I'm talking about long term. Long term NOACs are given typically for patients of atrial fibrillation so that they don't throw emboli from the heart into the brain or elsewhere. NOACs cannot be given in patients with mitral stenosis with atrial fibrillation, mitral regurgitation with atrial fibrillation. They have to be given in non-valvular atrial fibrillation. In valvular atrial fibrillation, warfarin still remains the gold standard therapy. So in non-valvular, if you have to give an anticoagulant, it might be better to give a NOAC because the repeated PT-INR requirement goes away. Also, dietary vitamin K need not be regulated as it is regulated in warfarin taking patients. So you can easily switch. The cost has become less of giving NOACs, so that also now is an advantage. The one problem with NOACs, of course, is that if the patient gets bleeding, it's not easy to get an antidote to that bleeding. Like we have protamine for warfarin, we do not have an easy access to antidotes, and the antidotes are expensive. That is one problem. But we do think that NOACs are a better option for non-valvular atrial fibrillation. Yes, sir.
Mm. And this COVID time, people keep on doing the D-dimer and keep the patients on antiplatelets. Or so, is it worth doing when the patient was not hospitalized or he did not have any signs of a thrombosis? So, we still, and how long one should take this?
Yeah. So COVID has exposed the medical fraternity like no other disease. COVID has exposed us for doing wrong things like no other disease has exposed us. And one area, as you said, is the D-dimer thing. So D-dimer, if say 500 is normal, and if we see 800 D-dimer, we will start an anticoagulant. Do remember that in the elderly, I'm talking about the elderly first. In the elderly, there is a false positive elevated D dimer very commonly. You will see 1000 in the elderly without any problem. So ignore, first of all, don't do D dimer until the patient becomes hypoxic. That is my thumb rule. If the patient becomes hypoxic, you must do D dimer. If the patient is admitted even before hypoxia, the patient will always be given Clexane. Enoxaparin is a rule in every admitted COVID patient. So D-dimer is a marker of inflammation of the intimal lining of the veins, and D-dimer therefore is an inflammatory marker, and use it as such in COVID. Never let D-dimer decide your outpatient anticoagulant therapy. Don't do that. Also, often, and we see this incorrectly happening, patient is discharged on oral anticoagulants like apixaban for 3 weeks, 6 weeks without any documentation of DVT or pulmonary thromboembolism. Don't do that. To give long term, that is 3 months or 3 weeks of anticoagulants, you need evidence of thrombosis in the form of Doppler of the legs or pulmonary CT angio. Otherwise, you don't easily give anticoagulants.
Right. Sir, we have been talking about the over prescribing. But I personally feel, and I need your opinion about the under prescribing of DVT prophylaxis in the perioperative patients, particularly patients who undergo surgery for the hip replacement or the knee replacement.
Sir, it is not just a perioperative under prescribing of
Yeah.
anticoagulants. It is also in ICU patients
Yeah, ICU.
who get
ICU.
admitted with pneumonia. ICU patients get admitted with many things in cardiac disease. We
Yeah.
under prescribe. We under prescribe, and short-term prophylaxis with NOACs or enoxaparin-like drugs is mandatory in patients. And there are easy scores available to assess risk of DVT in patients who are hospitalized. So short-term DVT prophylaxis is under-prescribed, and we should prescribe it more.
Yeah. One other important question asked came from the audience, and I also would have asked the same, that in spite of repeated teaching at all levels, people still use sublingual nifedipine for acute lowering of the blood pressure. Is it not a crime?
Yeah, so it is. As I said, the lecture should be titled, "In how many ways can we kill patients?" So one of the ways is using two sublingual drugs, sublingual sorbitrate and sublingual nifedipine. Sublingual nifedipine is outdated. So one thing you remember this first: in a patient who does not show end organ deficit, meaning the patient does not have stroke, does not have pulmonary edema, does not have acute kidney shutdown, and the patient comes with 200 by 130 BP, you don't have to bring the BP down in 10 minutes. You can easily give oral drugs, send the patient home, or admit the patient if you like, but don't precipitously bring down blood pressure because the patient does not have LVF. If the patient has LVF, give IV Lasix, furosemide, and get the pulmonary edema out. Otherwise, don't precipitously bring down blood pressure. That is very important. Also, if a patient comes with stroke, bringing down blood pressure precipitously can aggravate a stroke. About sublingual sorbitrate, never give sublingual sorbitrate in suspected acute infarction. Patient comes with chest pain, patient has ECG changes, you know it is an infarct, you know it is unstable angina. Don't give sublingual sorbitrate. Sorbitrate causes the steal phenomenon. It causes peripheral vasodilatation. Coronary blood flow actually decreases due to sorbitrate. Give the patient aspirin, clopidogrel, atorvastatin if you like. Don't give sublingual sorbitrate in a patient with acute myocardial infarction. Disprin reduces mortality by 22%. Keep disprin in your pockets. Keep disprin in the patient's pockets. Tell all your patients to keep disprin with them and save lives by giving disprin rather than kill patients by giving sublingual sorbitrate.
The patients and the relatives take pride that I have just given sorbitrate because I have it and he did not have it. And when we see they have hypotension, syncope, and all these problems. Another area, sir, that probably we are underusing is the vaccinations in elderly.
Okay. Oh yes, in the elderly, adult vaccination is a topic which I hope that you will teach on Medflix, and it's a very important area. But luckily, due to COVID, vaccination has come into limelight. Uh, Not just COVID vaccination, but even flu vaccination, pneumonia vaccination has come into the limelight. So my recommendations about vaccination are very detailed, but think of everybody above the age of 65 to give Prevenar, that is the uh, PCV13 vaccine. Give Pneumovax, that is the PPSV23 vaccine, to elderly patients. Give influenza vaccine. It's a shared decision. The patient is not compulsory, but if the patient has comorbidity like COPD, give the influenza vaccine every year to such patients. Uh, Unfortunately, herpes zoster vaccine is not available in India. That is another vaccine. If it comes, I would be keen to give the zoster vaccine to patients. So there are many vaccines that you can give to the elderly, and you should. Hepatitis B vaccination is incomplete in many patients, and you should take care of hepatitis B vaccination in the adult population.
Many of our elderly patients are receiving drugs for Parkinsonism, and they themselves are a very tricky problems in adjusting the dose about the anti-Parkinson drugs and the side effects. So, any specific instruction or advice you want to give?
Uh, as a family physician, the family physician will not be usually adjusting the dose of Parkinson medicines. The family physician has to be aware of the side effects of the Parkinson's medicine. The two commonest side effects that you should be aware of are psychosis and postural hypotension with syndopa, that is the combination of levodopa and carbidopa. If the patient is on this combination, every follow-up postural blood pressure should be checked, and you should ask the spouse or the family member about hallucinations. If they are there, you must inform the neurologist that patient is getting violent, patient has hallucinating, removing his clothes, throwing things around, and that can be a side effect of syndopa. So, side effects are most important to be aware of in neurological disorders because these drugs are not commonly given by us, so we are not experienced enough to regularly prescribe these drugs. Another area is dementia medicines. Similarly, dementia medicine cause significant anorexia, significant GI disturbance. And if the patient of Alzheimer's is taking some dementia medicine like memantine, or donazepam, then you must ask about anorexia, GI disturbance like diarrhea, and inform the neurologist that these side effects are occurring and should be reduced the dose. Because anyway, as you know, dementia medicines are not very effective medicines. They are given because the patient has memory problems. But the memory problems usually do not improve with the dementia medicines. So you may want to minimize the drugs of dementia if the patient is not eating well.
Excellent, sir. Excellent. We have got practically each and every aspect of internal medicine, not only in the elderly but also in the younger counterparts, and given many tips and insights. And we would have loved to continue, but we have already passed 1 hour, and I think it's time to thank you and all the viewers. And we'll definitely want you again and again on our platform to enlighten us. And I also learn a lot. Nivedita, are there any persons who what we call for on the stage or we close?
So we do have raise hands. Could we call Dr. Atul Parekh on stage?
Yep.
So I'm accepting your request. You'll be prompted to turn on your audio video. So you'll have to turn it on when prompted, and then you can come up on stage. I think I did see Sir on. Sir, we've accepted your request. You'll have to turn on your audio video.
Dr. Atul Parekh is a very senior physician, a very good friend, and he had been a professor and has many undergraduates and postgraduate students with him. And one of the great enthusiastic persons. Dr. Atul Bhai, welcome, and please have your questions.
Hello. Can you hear me?
Hello, sir. Hello, sir.
Yeah. Yes.
Tushar bhai, excellent as usual. I've been hearing you and so many
Yes, sir.
times I have heard you. My question is that we have got a lot of cases of chikungunya in Ahmedabad. I do not know about Mumbai.
Okay.
And we are faced with one problem of patient is not relieved of their pain if we use paracetamol. We
That's
have to
true.
use NSAIDs and sometimes combine it with the steroid, which is the best NSAID. You said naproxen, but sometimes naproxen doesn't take away their pain. So what else would you suggest?
Okay, so first of all, luckily chikungunya is more common in the younger people than in the older people. So that NSAID related toxicity.
I don't think Ahmedabad is,
Slight-
it's true in Ahmedabad. I
Achha.
myself is suffering from chikungunya. I'm 70 years old.
Oh wow. Okay. So,
So did I.
completely agree with you. Achha. I completely agree with you when you said that paracetamol does not work. It does not work. Usually we give paracetamol more as a placebo than as a real painkiller in chikungunya. Chikungunya is a frank arthritis. It's not just arthralgia. So we have to use NSAID. Sometimes some people use steroids also. After 3 months of chikungunya, many people start using disease-modifying anti-rheumatic drugs for chikungunya. So there is still confusion related to that. So about NSAIDs, I think the correct dose of naproxen is often not used. The correct dose of naproxen is 500 BD, and we tend to usually use 250 BD. So that is one thing. Diclofenac is a favorite amongst many people. I have removed diclofenac from my armamentarium completely. I don't use diclofenac except as an injectable occasionally in renal colic, but I don't use diclofenac at all. I have made a vow not to use diclofenac. Ibuprofen, if you want to use ibuprofen, correct dose in a 60 kg adult is 600 milligrams TDS and not 400 milligram TDS. So I would use ibuprofen. I would use naproxen, 500 BD. I would use short bursts of the drugs in chikungunya. I would use for 2, 3, 4, 5 days. Stop, withdraw, ask the patient to bear the pain and use it again for a few days intermittently. Intermittent use reduces the chance of cardiovascular and renal toxicity. I would always give a PPI whenever I use for a prolonged period or even if intermittently. So chikungunya is a tough disease, and I wish more is done to prevent chikungunya than to treat chikungunya. It is if somebody asks me what would you like to get, COVID, dengue, chikungunya, malaria, I would say last would be chikungunya. I'll get COVID, I'll get dengue, I'll get malaria. I will not get chikungunya. Yeah.
Tushar bhai,
What else do you use?
Yes, sir.
At
All
what
said
stage
and
would-
done.
At what
Yeah.
stage you would use steroids
I-
with NSAIDs?
Yeah, sir. I would not use steroids, sir, at all unless there are contraindications for NSAIDs. So if the patient's creatinine is 2.5, 1.8, and I can't use NSAIDs at all
Okay.
in such a patient, then
Okay.
for inflammation, I would use steroids. But otherwise, I would assiduously avoid steroids. Steroids also cause such a significant relief in pain
Agreed.
that often the patient will start self-medicating with steroids. So I would be very reluctant to use, and if I use, I would use it in short bursts of similar to NSAIDs. But NSAID contraindication should be there for me to
Your
use
audio
steroids.
not
But I know
audible,
I
not
know that
audible.
rheumatologists routinely
Something
use.
wrong with audio.
We can hear you, Atul bhai.
My audio?
We can hear you.
Okay.
And see, using a steroid very early has definitely shown that the inflammation is less and they don't go into chronicity. And using drugs like, I would say, deflazacort, that we have found that there is not much side effect if you use it for a week or two. And at the same time, it produces significant, reduces the morbidity.
Okay.
Yeah.
I have not read any papers on steroids being useful in early disease, so I would wait for such evidence to come. But my reluctance is always significant to use drugs which do not have scientific evidence. I would wait for some evidence like that. Somebody asked about nimesulide in chikungunya. Uh, Similarly, nimesulide, of course, is not safer than any other drug. In fact, the most hepatotoxic NSAID is nimesulide. So I'm not very keen on nimesulide. If you want to use a GI safe NSAID, then because I'm saying etoricoxib, which is GI safe, should not be used at all, then etodolac is a good GI safe NSAID. Etodolac. It comes in 400 milligram standard strength BD that you can use.
Right, but nimesulide I don't think is available outside India anywhere. I have not heard of nimesulide being used, and here it's used left, right, and center. But as you rightly said, tremendous hepatotoxicity and one of the most dangerous drug to me.
Yeah, I've rarely used nimesulide. Yeah.
Thank you for such a descriptive things you are told, and we have multiple queries that has been solved, sir. So I just want to have your experience on the topic vertigo, which is commonly seen in our day-to-day practice, and in many patients, despite of knowing the reason, multiple use of beta histamine, meclizine, we have been using the multiple things for that. So, what is your approach, and what is the role of this Vertin and Viclazine and Stamtil in such cases, sir, please?
So there are three important causes of vertigo that we know, and one of the three important causes is BPPV, benign
Yes.
paroxysmal positional vertigo. I suppose you are asking about BPPV. BPPV, the treatment for BPPV is not medication. The treatment for BPPV is a maneuver called the Epley maneuver, EPLEY. You must learn the Epley maneuver. It's a simple thing, and you must do the Epley maneuver before you start giving those sedatives, what we call vestibular sedatives like meclizine or stemetil, etc. The only drug that I do use sometimes is beta-histine, which is Vertin or beta-vert, etc. But Epley maneuver is something that is the treatment. You may have to do it once, more than once, but do use Epley maneuver. And always remember, in the elderly, what looks like BPPV may not be BPPV. So think of central causes of vertigo in the elderly. Vertebrobasilar insufficiency should be thought of. So think of that when the patient has ataxia along with the vertigo. Always think of vertebrobasilar insufficiency. Thank you.
We must thank Dr. Vivek for bringing out a very common problem that had to be discussed. Thank you, Dr. Vivek, for that.
Thank you.
Another Dr. Nagraj is asked about the antiviral drugs. It's a big topic, I suppose, but if you have to say in brief something, sir.
In family practice, the commonest antiviral drug that we use are those for herpes zoster, and the drugs like valsivir, or that is valacyclovir, acyclovir, or famciclovir are all safe in the elderly, and you should not change the dose in the elderly. And I don't know what other antiviral drugs he's talking about.
We give Tamiflu. Generally, we give Tamiflu also these days with influenza
Yeah,
like
sorry, I
illness.
forgot that.
Yeah.
For influenza, oseltamivir, that is Tamiflu, is a useful drug because we know that influenza causes more morbidity in the elderly.
Yes.
It is much more important to start oseltamivir in influenza within 48 hours of onset of fever. That is
Yeah.
very important. The duration has to be less than 48 hours for oseltamivir to be effective. So it is a good drug. It's a very good drug to prevent hospitalization in influenza, and it is also useful prophylactic drug. While
Yeah.
the therapeutic drug is 75 BD, the prophylactic dose is 75 OD for contacts of the elderly contacts of the patients of influenza.
I think now we'll have to stop, sir. Thank you very much for being with
Yes, sir.
us and having answered all the questions and covered the topic and absolutely impressed and learned a lot. And thank you so much.